Hola, buenas tardes. Estoy muy encantada de estar aquí y poder presentar unos proyectos nuestros a vosotros, pero esto lo voy a hacer en inglés. Porque I don't think I could even translate the title of my speech into Spanish. So we start from here, and we will go now a little bit deeper into what Michael was talking about. So we look more specifically at different intersection points and which are these kind of shared objects, information objects that we need to share between different kinds of actors within this system that we're talking about. So I don't think I have to talk too much about the current trends, because Michael, of course, gave a very nice presentation about the background, and it's clear that we have a shift into these integrated care models and towards also partnerships models where the family carers are part of the team and are considered to be experts, even the persons themselves or patients, whether they are patients or not, they are considered as experts contributing with their knowledge, which is a real societal shift. And we want to solve this by a combination of both formal and informal caregiving from the organizational point of view, which can be combined with self-care and lifestyle management, and which can be supported by technology and therefore be both locally or at a distance. But we want it to be controlled by the person in question, and that's why we talk about person-centered care. The aims of such kind of systems are to shape a collaborative environment and to look how we can share information, knowledge, and different kinds of workflows. And specifically, we want to close the gap between different care professionals, relatives, and the persons or patients. And also to bridge the gap between health and social care, which is one of our main aims, to have a real holistic picture. So what I'm going to tell about, so the first part at least, is based on a thesis of a former PhD student of mine who has researched these information flows and shared objects, and in the end we also built a system upon that, which was a kind of virtual health record. But I will pick more the information components today. The clinical context of this project was shared home care of elderly patients, meaning that there were people which have different kinds of disorders, they have multiple diseases, and they have complex interrelated problems. That means that they are in need of different kinds of services. Both healthcare services could be basic or more advanced, like palliative services, but these healthcare services are, of course, delivered by professional healthcare providers. But they are also very much in need of social services, like daily bathing or walking outside and help with different kinds of things, provided with meals and everything. And a enlarging role is given to the family carers around that take upon a lot of the work to be done. And these and several other kinds of relatives, because the relatives, they might be family carers, but they can also be relatives that live far away, so they are also in a big need of getting access to information, having trust that the person in question is taken care of, even if I am far away and cannot do it myself. So these were the kinds of problems we were looking into. And one is for sure that it was a great deal about collaboration, which is in need of improvement. So we started looking at two different questions. The one was what information do the different actors need? And we were working with social care workers, with primary care physicians, with nurses, with the family, and with the elderly patients themselves. In this project, we did not look at tertiary care or any hospital site, not secondary either. And we looked more deeply into, if we have this kind of scenario that we are working is, what are the information objects that are shared between these kinds of providers? Where can we grasp things that we can work on collaboratively? And the results of these studies are more detailed in the paper that I cite there, so you can easily read it. So, what was the results was to try to find these intersection points and to describe what is the current information exchange. A lot of it from the medical point of view was upon prescription lists, for example, which could be digitally in a physician's healthcare record system, but also a lot of it was on paper, so there was certainly no common prescription list, because it was some partly in electronic systems, other parts were faxed back and forth. You never did know what is the updated one. Then you went into the elderly's home and scanned the medicines and looked what's around laying there, but you did not know whether the patient took it or not. So one of these shared objects or common information components was certainly the medication of the patient. Then, or the prescription list. Other documents were like instructions that nurses gave to the home help services, because home helpers were often in charge on certain kinds of delegations, like dispersing the medicine and so on. So there was a lot of communication between district nurses and home care service personnel about their calendars. What should you do? You could not change a bandage after that the patient or before the patient should get a shower or something. So there were a lot of conflicting goals in each other care plans. So care planning was another thing which we found is very much in need of having a shared care plan, where also the relatives and the patients themselves can provide their own planning and to get this communication coordinated. So then we looked more specifically, okay, where are these kind of intersection points for information exchange, because they seem to be quite important triggers. If we can find them, we can describe these information components that are needed. And that was, of course, always if there were any specific changes from either side in the planning for this specific patient. So always if there was a change in something, it should of course be communicated to all partners involved. Another one was consultations in between different parties. The delegations that were given from one party to another. As the same thing with referrals, which is kind of a similar thing. And also if I, as one of the providers, want to some information to be shared to others. One important thing here is also that we had also first to shape a holistic view of this entire process for each of the actors, because each actor had its own view. So you could not just say, okay, now we build a system where you can mark who the information should go to, because the one sitting on some information was not really aware of that it could be important for another party. So they did not know that. It was first through collaborative work that they found these things out. So we started a lot with sharing much information and then trying to reduce it. and see what is really necessary. And another intersection point is, of course, the coordination of planned activity, which is very much the care planning part. And then we looked, okay, if we have the intersection points and we know more or less who is communicating with whom and when and which kind of information they are sharing, then we tried to look what are these shared components. And we had a number of IT systems. Is this a fire alarm? Over? So what you see, the database symbols green colored, are databases or information components that are stored in different providers' electronic systems, which is a nursing record, a primary care physician record. It is a care plan that is only be put up by one professional group, like a nursing care plan, for example. And then we saw that parts of these records and care plans are information that should be communicated or shared. And this was the ones that are the light ones in the cloud. So at that time there was no cloud computing, but we could put everything in the cloud, which we then call the shared care plan. Risk factors are such essential elements that should be shared, of course. And also the calendar, because you need it for the time planning of the care, and the prescription list, as I already said. And also partly part of the notes, not everything, because very often, of course, the old documentation is not really relevant. So we document a whole lot, but we never use it later on. So then, of course, the question was, how did we elicit this information? So we also worked on a more detailed method for eliciting the exact needs, which is then presented in another paper. And this was based on scenarios. So we worked with a lot of focus groups, partly only single professional groups, and then we matched them together. So we always worked with each group in detail, and then we put interdisciplinary groups together to get this common view for them. And we always had a detailed analysis of the different work situations and described the actual activities, how they are done currently, and then how they would like to work if they could or if they had the possibilities, and analyzed who cooperated with whom and which information they shared and so on. And especially with the focus on how would you like it to be changed, of course. And the benefits from using these focus groups and working with real scenarios that were understandable to all the professionals was, of course, that they get this interdisciplinary understanding, that they see the entire process, and they gained much more insight into each other's problems, so they could understand why should I deliver a certain amount of documentation. And we always try to keep the documentation part at a minimum. For example, when we had home helpers going out with mobile devices, they had their care plan in the device, so they were only asked to, check if everything was done according to the plan, or document anything that deviated. So we only documented deviations. We did not document the regular work, because this was standard. But if something unexpected happened, then it could be communicated and everybody had it accessible. And by reducing the amount of data, it was of course also easier to visualize it on small devices and to to have instant access to relevant information. And we also saw that it improved the relationship between the family and, for example, the home helpers or the healthcare professionals going to the homes, because they had access to a calendar view what happened with the patient in the home. So they could see, okay, somebody, a nurse has been at home and she has done this and that according to the plan, even if my mother and father, who perhaps has a slight dementia, says that nobody has been here today. So it really reduced the number of telephone calls to the social care services, who very often could not answer before because they did not know what the nurse had done, for example. And it's also easy to build on these scenarios for later implementation of IT technology, of course, because you have the requirement specifications practically. So from all these requirements, we went to implement what we call the virtual health record, where we integrated all these information pieces from different legacy systems or underlying feeder systems, as we call them, base systems, and made a mediator, and where we presented then these entire overview in different kinds of devices, which could be small mobile devices or a usual computer or a web page. And we were also able then to document information at the point of care and turn it back to the base systems. The only thing we had to use was a separate mediator database to storing additional information, because we also found information that was not in any base system. A typical example was the prescription list, which did not really exist because it was only partly existing in the different legacy systems, and the rest was on paper, so we made additional documentation and could only store it locally. Yeah, and this was the kind of implemented application, what we call the virtual health record, where district nurses, patients, relatives, and home helpers work together, where they could see, for example, an integrated care plan, and with the colors you see whom documented what, so you see from which kind of base systems the documentation comes, and you can always add additional things here. Also, this is a web application for the patients or the relatives to see which is the medicine they are standing on, and it was the patients to decide upon this view for the relatives, which parts of this view they should see. Should they only see my medical contacts, or should they be able to see the prescription list? Should they be able to see my care plan or not? So by having it in different parts of this record, we could easily set access rights on each of the pages. And that's a doctor's view about the medication list. And when district nurses had their application, they got automatically notifications from the doctors, for example, when there was a new prescription. So this was one of the intersection points. When there was something new happened, I automatically get a notification about it, and so on. Over that. Actually the same happened for the home help services. Of course, they always got notification if something new happened, and they could see added instructions from the nurse, what they should do, and so on. But they had smaller devices because they were very mobile, of course. This project was actually, it was finished as a research project in 2005, and then we had an implementation part between 2006 and 2008, and it's still running in one municipality. But from this project we built upon, and with another project called WIPA, where we look at specifically at stroke patients from acute care, hospital care, down to this situation which we had in the home care, so we can capture even the hospital processes. It's something which we are doing in more detail now, and we have in my research group a kind of mixture of projects. So all these purple ones are our research projects that we run. The blue ones are when we are working together with either municipalities or county councils or both. So that's more implementation projects or combined projects where we have the healthcare or social care providers as a project leader and we do the research parts on that. But it's very much based on previous projects that we have, and the green ones are national projects like infrastructure in general for health and social care, and My Healthcare Context, which is more like a portal for patients and citizens, but where we also now go more deeply into all the different processes and workflows and see how we can visualize them for patients and to find all this information, intersection points and processes in more detail. So I will shortly describe you just the one. If you see here, if we had Old at Home first, I take something about WIPA because there you see some new things that we run into another detail level, and that was where we took stroke as a case because there we have, of course, we can work with the medical professionals with a specific group, but nevertheless stroke patients usually have multiple diseases. They don't have only stroke. It's a number of complications that they have, which makes it from an informatics point very interesting. So we started also here to make the modeling of the different work processes, and what you see in this is just a usual process model. What happens when the patient is discharged from hospital, so this is this part of the process, and in red you see where there are lacks in either timely transferring information, lack of information, or communication problems. So it can be different kinds of problems that you have to look into, and this will lead you always to these intersection points that you need to form your shared information objects. So what we did was that we went from this, what I call high-level problem that we had in the previous slide. So one of these red areas, the second one was insufficient handover at discharge. So we took this then as a high-level problem, detailed it more in some sub-problems that we wanted to solve and related them to problem classes. So this breakdown will also do that we can map these different problem classes to higher aims, as for example they exist in health strategies, making that if you detail with these process models and the information flows, you never lose the relationship between a health or social care strategy that you have in your organization and the later on implemented information or IT systems. So we looked at these three kindly different problems, even if they relate to the same high-level problem, but you have timely delays, you have a lack of coordination, and you have insufficient information that is transferred. So it's three different kinds of problems: time, organizational problems, or information problems. So even here, you could, of course, solve it with an e-service for supporting this specific problem. And here you see what I meant with these strategic goals, because you take these smaller concrete problems and relate them to the low-level goals or which are related to high-level goals of a strategy. So you have a transparent process. And then of course you have to detail with what I had in a former project, what are the exact information needs and the components to detail the e-service and transform it as you want. So this was part of what I was thinking, telling you about intersection points and information objects. And we will have in next June in Rome a conference or a track, special track, where Albert and Michael are also participating on this topic of patient-centered health and social care. So if there's anybody of you working on this, so you're very welcome to submit papers. Thank you.